Good morning, students. Welcome to the next video in your odontogenic tumors. So we have discussed most of the important odontogenic tumors and the questions regarding it. Okay, so in this video we will discuss about certain odontogenic tumors which are equally important for your NEET INCT examination. They have already picked up many questions from these areas. Okay, so first of all, I would like to discuss about an odontogenic tumor that is cementoblastoma. Okay, cementoblastoma. Blastoma. So cementoblastoma is an odontogenic tumor of your cementum. Okay, your cementoblast. Okay, so that tumor is a true cementoblastoma or true cemental tumor. Okay, true tumor of your cementoblast. So origin is from your cementoblast. Now you can imagine, what does a cementoblast do? It makes up cementum, right? It makes cementum. So what happens if this cementoblast get a tumor? It will make more and more and more cementum. Okay, and you know that the cementum is along the roots. Okay, along the roots of the tooth, and along the root of the tooth, more and more and more cementum is deposited. Okay, so that is what happening here. Cementoblastoma. Cementoblastoma is a true cemental tumor. Okay, true tumor of your cementoblast. Okay, or true cemental neoplasm. Now it is very rare. It is very rare. Less than 1% of the odontogenic tumors are this cementoblastomas. Okay, and there is a peculiarity for this. The most common site for the occurrence, okay, most common 90% of the cases, they occur in the mandibular first molars. Mandibular first molar tooth is the most common tooth which is affected by this cementoblastoma. Mostly it is coming in the first molars. Okay, so it is mostly concentrated. 75% of the cases, they comes in the mandibular molar premolar region. Okay, molar premolar region is the very favorite site. And one interesting thing here is that the patient will have pain. So patient will come with pain. Okay, so imagine your patient is coming to your clinic with a pain in the molar tooth, and you see that the molar tooth is perfectly fine. There is no caries. Okay, no caries, no pulpitis. Okay, no pulpitis. The tooth is very much vital. Tooth is vital. There is no periodontitis. Okay, so nothing is there. Nothing is there. The patient is saying that I have pain in the molar tooth. Okay, and you give him what is the first line you will give? You will give him NSAIDs. Okay, you are giving NSAIDs, but at night the patient will call you and give you a good speech that sir, your NSAID worked very well. I have no relief. Okay, no relief. He will call you and give you a good night. Okay, so see, there is pain, and in the tooth there is no symptoms, no caries, no periodontitis, nothing is there. The patient is just complaining of pain, and you give him NSAIDs and there is no relief. So what you will tell to the patient? Okay, please come to the clinic tomorrow. I will have a radiograph. So you are going to take a radiograph, and in the radiograph, what you are going to see? You are going to see something like this. Okay, so this in the radiograph, you are going to see something like this in the molars of this person. You can see that there is a big radio opacity. This is a radio opacity, and that radio opacity is attached to the tooth root. You cannot see the root apex. Okay, root apex, the root canal is not seen. You cannot appreciate. It is inside a radio opacity. Okay, you are seeing a big radio opaque lesion. Can you see this? This is a radio opaque lesion, and it is surrounded by a radiolucent rim. You can see a radiolucency around it. So how is the radiograph? A radio opacity surrounded by a radiolucent rim, and that radio opacity is attached to the tooth root, where you cannot appreciate the root canal or the root tip or the root apex. You cannot appreciate. Is this clear? This image. Okay, so this is how a radiograph look like for a cementoblastoma. Okay, for a cementoblastoma. So what is you gonna do? You're gonna extract the tooth along with this tumor. You will do a surgery and remove it. Okay, so in the histopathology, there is nothing much in the histopathology. What you are gonna see is, in the histopath, what you see is, you see cementum. So much of cementum deposited in layer by layer. Okay, you see so much of cementum, and you will see cementoblast. Okay, cementoblast is seen, and the cementum is deposited layer by layer. Okay, deposited in a layer pattern or lamellar pattern. Okay, so that is deposited layer by layer, and that is called pagetoid appearance. Pagetoid appearance. Okay, in layer by layer the cementum is deposited. Okay, this is what you see in a cementoblastoma. Okay, this is what you see in a cementoblastoma, and this is how the cementoblastoma is appearing. So there is this picture. You can use this picture to differentiate many lesions. Here you see cementoblastoma. Here cementoblastoma. In cementoblastoma, you can see that the radio opacity is attached to the tooth root, and it is surrounded by a radiolucent rim, and you cannot see the root apex. But in hypercementosis, you have radiolucency, but it is attached to the tooth surface, root surface, and but you can see the root apex there. Okay, it is not a masking, it is not that radio opaque to mask the root canal or the root apex. Okay, in idiopathic osteosclerosis, in osteosclerosis, the bone below the root apex is having some sclerosis, or it get radio opaque. This is due to small irritation, very low grade irritation. You get a idiopathic osteosclerosis. Okay, if some slow irritation is going from the root to the tooth to the root apex, and that because of that slow irritation, our body will try to seal it off, and there is some sclerosis. And in condensing osteitis also it same happens. You can see that due to a small caries there, and you can see that it is getting sclerosed. And cemento-osseous dysplasia, we will see cemento-osseous dysplasia in fibro-osseous lesion. You can see that in cemento-osseous dysplasia, you can see radio opaque lesions in the root apex in multiple bits. Okay, multiple bits of radio opaque lesion. Okay, this is how we differentiate different lesions. So that is about your cementoblastoma. And another thing I would like to discuss is your myxoma, odontogenic myxoma. Okay, odontogenic myxoma. Now, you know that odontogenic myxoma, what is the importance of odontogenic myxoma is that it is the third most common odontogenic tumor. Okay, third most common odontogenic tumor is your odontogenic myxoma. So first comes your odontoma, second comes your ameloblastoma, and third comes your odontogenic myxoma. Now, peculiarity of this odontogenic myxoma is that it mostly comes in the mandible. It is favoring the mandible more than the maxilla. And see how this is how a odontogenic myxoma look like. Okay, it is having so much of juicy material. Okay, it looks like very juicy material because of the presence of a substance called hyaluronic acid. So it contains so much of hyaluronic acid, and this hyaluronic acid help in the dissolution or resorption of this bone. Okay, so they are rich in hyaluronic acid, and this resorption of bone here, can you see this area? They have this radiolucency, and the radiolucency will have multiple locules. Okay, this radiolucency, you can see multiple locules of radiolucency, radiolucency, and that appearance has a particular name. That appearance is called tennis racket pattern, or we say step ladder pattern. Step ladder means it is having locules of radiolucency. Okay, locules. So there is a radio opaque region here, then comes a trabecular portion, then again a radio opaque lesion. So it is looking like a tennis racket. Can you appreciate it here? Okay, so there is radiolucency in between the trabeculae. In between this radiolucency, we have trabeculae. Can you see here this portion? I think it is more clear. Okay, so in between this radiolucency, you have trabecular bits of your bony trabeculae. So it is looking like a multilocular pattern, a tennis racket, just looking like a tennis racket, or a step ladder, just like ladders. Okay, in between you have hole, and there is trabeculae in between. Okay, so this is about your your odontogenic myxoma. So they are very much rich in hyaluronic acid. And what other things you can see that in odontogenic myxoma, you have a high level of hyaluronic acid, high level of alkaline phosphatase. There is an increased level of alkaline phosphatase, increased level of lactate dehydrogenase. These enzymes are increased in this tumor, because these enzymes are very much responsible for bone resorption. Okay, so it is very locally aggressive lesion. It is very locally aggressive, so that it will dissolve all the bone here. So this is about certain two other odontogenic tumors which are very important for you. Okay, rest of the odontogenic tumors are not much asked. You can have a read in your Schaefer. Okay, so see you in the next video with the next topic.